iTech India welcomes all the participants. Today's regional distance learning seminar series. Today's topic is PPTCT and ART in a pregnant woman. And today's speaker is Dr. Suresh, Senior Medical Officer, pCoE, ICH. We welcome you, sir, and request you to start the session.
Good afternoon to everyone. Today I am going to talk about PPTCT and ART in pregnant women. PPTCT is prevention of parent to child transmission. For next 1 hour, I am going to elaborate the PPTCT program in India. Next. So what are the session objectives of this class is, we have to know the burden and PPTCT services available in India. What are the essential package of PPTCT services? What is the four-pronged strategy for PPTCT? And what are the current infant ARV prophylaxis followed in the NACO program? And the 10 different case scenarios on PPTCT, and what are the infant ARV prophylaxis followed for the different case scenarios. Next. So in 2020, the estimated 81,430 children estimated to be living with HIV, that is accounting for 3.5% of the estimated HIV infections. That is 20,930 pregnant women who required ART to prevent MTCT, mother to child transmission of HIV. It is a 2020 HIV estimates. Next. So this slide shows the risk of HIV transmission from mother to child with or without interventions. In the era of no ARV, when the HIV positive woman not taking ART breastfeed, the chances of transmission is 30 to 45%. If the no ARV and no breastfeeding, the chances of transmission is 20 to 25%. Whereas previously we are given short course with one ARV and breastfeeding, the chances of transmission is 15 to 25%, and the short course with one ARV and no breastfeeding is 5 to 15%. Currently, we are giving three ARVs with breastfeeding. The chances of transmission is less than 2%. The mother opts for no breastfeeding and taking ART triple drug regimen with good adherence, the chances of transmission is less than 1%. Next. So the prevention of parent to child transmission is being implemented under National AIDS Control Program to achieve the goal of elimination of mother to child HIV transmission. What is the vision? Women and children should be alive and free from HIV. What is the goal? To work towards the elimination of pediatric HIV and improve maternal, newborn, and child death and survival in the context of HIV infection. The key objective is to ensure that available integrated PPTCT services delivery with existing reproductive and child health program. Next. So the India is committed to achieve the EMTCT goal of HIV so that no child is born with HIV and the mothers are kept alive. What are the targets for the process indicators for validation of EMTCT is to be maintained for at least 2 years or as follows. Greater than 95% of all estimated pregnant women are registered for antenatal care and receive at least one antenatal coming for regular checkup should be tested for HIV, and greater than 95% of HIV positive pregnant women are on ART. Next. What are the essential package of PPTCT services available. We have to give routine HIV counseling and do a testing to all pregnant women enrolled in antenatal care with opt-out option. Then ensure the involvement of the spouse and other family members in their successive visits and move from antenatal care centric to a family centric approach. Then we have to provide, if they are found to be positive, we have to provide lifelong ART as per national guidelines to all pregnant and breastfeeding HIV infected women, regardless of their CD4 count and the clinical stage of the woman. Along with it, we have to give care for the associated conditions like STI, RTI, TB, and other OAS. We have to monitor the hypertension, diabetes in every visit. Then we have to promote institutional deliveries of all HIV infected pregnant women registered. Then we have to mainly perform a plasma viral load testing at 32 to 36 weeks of gestation to determine the risk of HIV transmission to the baby. This last point is very important. Currently is following in all PPTCT program. They have to do a viral load testing at 32 to 36 weeks. Next. Then after delivery, we have to provide ARV prophylaxis to infants as per national guidelines. And we have to provide nutritional counseling and psychosocial support to HIV infected pregnant women. Then we have to provide counseling and support for initiation of exclusive breastfeeds within an hour of delivery. This is very important. We have to give an exclusive breastfeed and we have to start within an hour of delivery, and it's a preferred option and it has to be continued for 6 months. Integrate and follow all the HIV exposed infants into routine health care services, including immunization at 6 weeks, 10 weeks, 14 weeks, 9 months, as the unexposed infants, and ensure the initiation of a CPT, 4-trimethoprim prophylaxis at the 6th week of life, and also do an early infant diagnosis using HIV DNA PCR at 6 weeks of age onwards as per NACO EAD guidelines. Then we have to strengthen the community worker, outreach worker, through local community networks to support these HIV positive pregnant women and their families. And if they are found to be lost for follow-up, with the help of the NGOs, networks, we have to enroll the patient in the program. Next. What is a 4-pronged strategy for PPTCT? The first prong one is the primary prevention. HIV negative general population. Prong 2 is HIV positive, not pregnant. We have to do family planning counseling in ICTC and but more importantly at the ART centers and CSC. Prong 3 is HIV positive and pregnant. We have to prevention of the mother to child transmission. Then comes prong 4 is care, support and treatment. HIV positive mother, we have to link with the networks and NGOs. So first prong 1 is the primary prevention. Second is prevent the unintended pregnancies. Third one is the prevention of mother to child transmission. Fourth prong is the care, support and treatment. Next. What are the risk factors associated with the increased parent to child transmission of HIV? There is 2 different major risk factors. It's maternal and obstetric factors. Second one is the infant related factors. In maternal and obstetric factors, if there is a recent HIV infection in the mother and the mother is having a high viral load and advanced HIV disease like stage 4 illness or the CD4 count is less than 100 or less than 200, if the mother is having a sexually transmitted infections, and if we follow a obstetric procedures like forceps, vacuum delivery at the time of labor, and if you prolong the labor, and if you do repeated invasive fetal monitoring, and if the mother is malnourished, maternal malnutrition plays a major role, and also the conditions of breast like sore nipple, breast abscess, mastitis. This will increase the risk of HIV transmission from the mother to child. So next comes the infant-related factors. So preterm, low birth weight babies, and the condition of baby's mouth like oral ulcers, thrush, and the third one is the main point is the mixed feeding. So we should avoid mixed feeding. We have to take care of the condition of the baby's mouth, and we have to prevent preterm delivery or an low birth weight baby, and also we have to take care of the mother in the antenatal checkup of the condition of the breast, and also we have to take care of the maternal malnutrition. So, and also we have to treat the coexisting sexually transmitted infections. Next. What are the PPTCT interventions during pregnancy? We have to provide HIV information to all pregnant women in the antenatal checkup, and we have to advise and strengthen the antenatal disease, and this will give an opportunity for the PPTCT, and the prevention of this PPTCT through giving a triple drug regimen, antiretroviral therapy, and we have to referral for viral load. All HIV positive pregnant women, they referred for a viral load between 36 and 36 weeks of pregnancy, and to determine the ARV prophylaxis of the child depending on the risk. The main thing is that we have to counsel them for an institution delivery so that the interventions for the PPTCT can be undertaken, and also we can prevent the mortality also. We have to mainly counsel them on infant feeding practices, that is to exclusive breastfeeding up to 6 months, and we have to give available ARV prophylaxis for that child, and we should mainly consider the safe obstetric practices, avoid invasive fetal monitoring, and avoid prolonged labor. These are the main PPTCT interventions during pregnancy. Next. What are the infant feeding options available? Major two part is the exclusive breastfeeding or exclusive replacement feeding. What is meant by exclusive breastfeeding is, exclusive breastfeeding means giving a baby only breast milk and no other liquids or solids, not even water. Normally we give vitamin D syrup and multivitamin syrup are permitted for this HIV exposed babies, and we have to provide the infants with all required nutrition and the immunological factors. And the breastfeeding should be started within 1 hour, both in the normal vaginal delivery and in the cesarean section delivery. Maximize the chances of survival of these infants, and is recommended as the preferred choice of infant feeding for HIV exposed infants in India. Exclusive replacement feeding. Next option is the exclusive replacement feeding. The exclusive replacement feeding is the process of feeding a baby who is not breastfeeding with a diet that provides the baby its nutrition requirements. Replacement feeding including feeding the baby with animal milk, dairy milk, and infant formulas. The feed must be prepared in a hygienic manner and should be given with a spoon and bowl. You should avoid bottle feeding. You prefer a holiday feeding. Next. The major factor increases the risk of transmission of HIV is the mixed feeding, and it should be better avoided. So when exclusive breastfeeding is not possible for any reason, like mother is having a major maternal illness, and if it is a twins, mothers and healthcare workers can be reassured that maternal ART reduces the risk of postnatal HIV transmission in the context of mixed feeding as well. And the healthcare providers and counselors should be trained to help pregnant women couple in reaching the right decision and to support them in implementing their preferred choice. Next. So what is the current national guidelines for infant feeding in HIV exposed and infected infants less than 6 months of age? Exclusive breastfeeding to be recommended for the first 6 months of life. Beyond 6 months of age, breastfeeding should continue with while complementary feeds are introduced. Breastfeeding should only stop once a nutritionally adequate and safe diet without breast milk can be provided to the child. So, mother living with HIV should breastfeed for at least 12 months and may continue breastfeeding for up to 24 months or beyond, like the general population, while being fully supported for ART adherence. Why they keep on strengthening about the exclusive breastfeeding is, see, under 5 mortality is very common in India. That too in less than 1 year is more chances of death will occur, and less than 1 year for an HIV exposed child means more chance of die due to diarrhea as well as the pneumonia. So to prevent the diarrhea, better we can give an exclusive breastfeeding and we should prevent the mixed feeding. Next. If the HIV positive mother plans to return to work, she can be reassured by SCVs that shorter duration of breastfeeding of less than 12 months is better than never initiating breastfeed at all. So breastfeeding is made safe by giving ART to the mother and ARV prophylaxis to the baby. So if you give a ART triple drug regimen to the mother and it will suppress the virus load, and there is a less than 1%, less than 2% chance of transmission virus to the babies. And even though it spread also, if you give ARV prophylaxis to the baby like nevirapine and zidovudine, the chances of transmission to the baby is very minimal. So, with optimal adherence to ART, the suppressed maternal viral, there remains no difference in infant feeding guidelines for HIV exposed versus unexposed infants. So, along with it, mother should follow the protected safe sex practices by using condoms and ART adherence to reduce the risk of HIV transmission to the babies. Next. So, what ARV drug we are currently using for pregnant women? Under the national program, it is recommended to provide a lifelong ART for all pregnant and breastfeeding women living with HIV, where all pregnant women living with HIV receive a fixed drug combination, FDC, triple drug ART regimen, regardless of the CD4 count, their clinical stage, both of their own health, and to prevent vertical HIV transmission and for additional HIV prevention benefits. Presently, as per national guidelines, TLD, tenofovir, lamivudine plus dolutegravir is the preferred regimen for the pregnant woman. Next. ARV prophylaxis is advised to the infant based on the risk of HIV transmission. So there is two chances, low risk and high risk. So for a low risk, regardless of the type of feeding, we have to follow single drug ARV prophylaxis is advised in infants with low risk of HIV transmission for 6 weeks. Whereas dual drug ARV prophylaxis is advised in infants with high risk for HIV transmission and the duration of which depends on the type of feeding for 6 weeks if on replacement feeding and 12 weeks if on breastfeeding. So I will repeat once again, there are single drug ARV prophylaxis and dual drug ARV prophylaxis. Single drug ARV prophylaxis is advised for patients for low risk HIV transmission, and it has to be continued for only 6 weeks, regardless of the feeding type. Whereas dual drug ARV prophylaxis is advised in patients with high risk transmission, and the duration, which depends on the type of feeding. For 6 weeks, if it is a replacement feeding, and 12 weeks if on breastfeeding. Next. So how the ART works in preventing the transmission of HIV in this PPTCT program? So it reduces the maternal viral load in a target not detectable level, and it loads the fetus with the triple ARVs, and that prevent the transmitted virons from replicating and improving the overall health of the mother, and the quality of the life will be improved, and the mother will be free of opportunistic infections, and mother will be free of any sexually transmitted infections, and the CD4 count will improve. And also it reduces the risk of transmission virus to the HIV exposed infants. Next. So the ART regimen in pregnant and breastfeeding women with HIV. What is the target population? Pregnant or breastfeeding women with HIV. What is the preferred regimen? Tenofovir, lamivudine, dolutegravir. So TDF means tenofovir. The available strength is the 300 mg. 3TC is lamivudine. The available strength is 300 mg. Dolutegravir adult dose is 50 mg. So 300 plus 300 plus 50. It comes in the fixed drug combination. It has to be given once daily. So it including HIV-1 population, HIV-2, HIV-1 and 2, and the woman exposed to single dose nevirapine in the past, and the PLHIV is co-infected with TB or hepatitis, all should take a TLD regimen. And pregnant woman with HIV should be educated about the benefits and risks of DTG, dolutegravir, to help informed choice. Next. So, what care we have to take in patients coming directly into the labor? The labor room nurse offers bedside counseling, and they have to offer HIV screening test. If the woman concerns and screen for HIV using the whole blood fingerprint test, rapid test, in the delivery room or labor ward. If patient is reactive to HIV antibody, the medical officer in charge will initiate the ART as per the guideline and ensure HIV confirmation at the ICTC center. The labor room nurse in ICTC, we have to use 3 different types of kits, and we have to confirm the HIV positive. Labor room nurse informs the ICTC counselor and laboratory technician for further confirmation of HIV status as per guidelines. If they are tested negative at ICTC, the ART is stopped. If HIV positive status is confirmed at ICTC, ensure linkage to ART center and collect blood for CD4 count and continue the ART as per guidelines. What is the highlight of this point is, a patient comes directly to the labor means we have to offer give a counseling, and the woman consent for it. We have to do an whole blood fingerprint test, and if they are found to be positive, we have to start the TLD regimen, send the sample, or refer to the ICTC. If they are found to be positive, have to continue the ART. If it is negative in ICTC department, we have to stop the ART. Next. So, what drug we have to give in intrapartum and postpartum? So, intrapartum, if the patient is presenting in active labor and they are not at all on ART, earlier means we have to initiate intrapartumly, we have to initiate TLD regimen We have to continue in the postpartum stage, TLD. Next. Next. So earlier I told there is a two risk status of the infants. According to that, the ARV prophylaxis differs. See, this next two slides is very, very important because I often get a phone call from the medical officers regarding this, the infant ARV prophylaxis. So there are two different types of risk status. One is the low risk status. Second one is the high risk status. Low risk status is for the 6 weeks and regardless of the feeding option. So, low risk status, infant born to mothers with a suppressed viral load, that is less than 1000 copies per ml, done any time after 32 weeks of pregnancy up to delivery. They are said to be low risk infants. Earlier I told that all the HIV positive pregnant women has to undergo viral load testing at 32 to 38 weeks of delivery. So at the time of test, the report is less than 1000 copies per ml, labeled as low risk infants. For them, either we have to give syrup nevirapine or pseudovidin. When we have to consider pseudovidin, infant born to mother with confirmed HIV-2 or HIV-1 and HIV-2 combined infection. Infant born to a mother who had received a single dose of nevirapine during early pregnancy or delivery. An infant born to a mother who is on PI-based ART regimen due to treatment failure. What is the duration of this ARV prophylaxis? From birth to still 6 weeks of age. So, low risk infants means if the viral load report is less than 1000 copies per ml after 32 weeks of gestation, delivery, 32 weeks of pregnancy up to delivery. There are two drugs currently we are giving in the NACO program, nevirapine or pseudovidin. Nevirapine is most commonly given. If nevirapine is not available or contraindicated, in that case, we have to give pseudovidin. What is the dose? Pseudovidin indication is HIV-2 infection or HIV-1 or HIV-1 and HIV-2 infection, or the mother is already exposed to single dose nevirapine in the early pregnancy or delivery, or mother is on PA-based regimen due to treatment failure. What is the duration of this drug for low risk infants? It is only 6 weeks of age. When pseudovidin syrup is not available, syrup lopinavir should be used after 14 days of birth. But currently, lopinavir syrup is not available. Can try lopinavir pellets also. Next. So next comes the high risk infants. Infants born to HIV positive mother or not on ART, and the maternal viral load not done after 32 weeks of pregnancy to delivery, and maternal viral load not suppressed between 32 weeks of pregnancy to delivery, mother newly identified HIV positive within 6 weeks of delivery. In the earlier one, known positive women who have done viral load test at the 32 weeks of pregnancy to delivery. In this case, high risk is mother, infants born to HIV positive mother, not on ART, maternal viral load, even if they are in on ART and the viral load is not done and the viral load is not suppressed and mother is newly identified after delivery, after within 6 weeks, they have to give dual ARV prophylaxis, like syrup nevirapine plus syrup pseudovidin. What is the duration? In this case, if the mother opts for exclusive breastfeeding, we have to give 6 weeks of age. The mother opts for exclusive breastfeeding, we have to give for 12 weeks of age. So when pseudovidin syrup is not available, syrup nevirapine should be used for the first 14 days after birth, and after that, add syrup lopinavir till 6 weeks in case of ERF or 12 weeks in case of exclusive breastfeeding. Another alternative is we can give the isotalin pediatric formulation. So low risk means single drug regimen, 6 weeks. High risk means We have to do dual drug regimen for 6 weeks in case of an exclusive replacement feeding, 12 weeks on exclusive breastfeeding. Next, dose of syrup nevirapine 10 milligram per ml. So normally Indian child will be 2 to 2.5 kg or more than 2.5 kg. So the birth to 6 weeks, birth weight 2 to 2.5 kg, 10 milligram, that is 1 ml once daily. If the birth weight is greater than 2.5, 2,500 grams, we have to give 15 milligram or 1.5 ml once daily. In 6 weeks to up to 6 months, 20 milligram, 2 ml once daily. 6 months up to 9 months, we have to give 30 milligram, 3 ml once daily. Greater than 9 months, until breastfeeding ends, 40 milligram, 4 ml once daily. So any HIV exposed breastfeeding baby comes to ART center beyond 6 weeks of age will need SASM or pCoE opinion for indication of dual prophylaxis. So what point we have to remember is the 1 milligram of nevirapine contains 10 milligram. So for 2 to 2.5 kg, we have to give 1 ml. More than 2.5 kg, we have to give 1.5 ml once daily. Next comes the zidovudine syrup. Less than 2 kg, 5 milligram dose twice daily, 0.5 ml twice daily for 6 weeks. 2 to 2.5 kg, 10 milligram dose twice daily, 1 ml twice daily, 6 weeks. Greater than 2.5 kg, 15 milligram per dose twice daily, 1.5 ml twice daily, 6 weeks. So difference between the nevirapine and zidovudine is for 2 to 2.5 kg is 1 ml once daily for nevirapine, twice daily for zidovudine. Greater than 2.5 kg is 1.5 ml once daily for nevirapine prophylaxis. In this case, zidovudine 1.5 ml twice daily. So zidovudine means twice daily we have to give, whereas nevirapine means single dose is enough. Next, the use of syrup lopinavir retinol. The syrup lopinavir retinol should be used for infant prophylaxis in certain specific situations. It should be used in infants only after 14 days of their birth. When zidovudine syrup is not available, syrup lopinavir retinol should be used after 14 days of birth. When zidovudine syrup is not available, syrup nevirapine should be used for first 14 days after birth, and then add lopinavir retinol till 6 weeks in case of exclusive replacement feeding, or 12 weeks in case of exclusive breastfeeding. Next. So this is the formula for lopinavir retinol. For 2 weeks to 4 weeks, less than 3 kg, 2 to 3 kg is 0.6, 3 to 4 kg 0.8 ml, 4 to 5 kg is 1 ml twice daily. Greater than 4 weeks, 3 to 6 kg 1 ml twice daily, 6 to 9 kg 1.5 ml twice daily. So the lopinavir is 300 milligram and ritonavir 75 milligram per meter square of body surface area per day. It is to be given twice daily. Both the zidovudine and lopinavir ritonavir should be given twice daily. Next. And lopinavir ritonavir should be avoided less than 14 days. So the infant ARV prophylaxis highlights are infant ARV prophylaxis should be started immediately after birth or at the first encounter with health services. It can be started even if they report to you more than 72 hours. And though its efficacy in preventing perinatal transmission will be lower, we have to start them on ART. It will, however, still be protective towards the transmission by breastfeeding. Daily infant ARV prophylaxis should continue for minimum of 6 weeks, during which the mother should be linked to appropriate ART services. A longer duration, 12 weeks of prophylaxis, is needed for infants on breastfeeding because still there is a chance of transmission of virus through breastfeeding. That's where we are giving prophylaxis for 12 weeks. Next. So it's a repeat one. The infants with the low risk of HIV transmission, exclusive breastfeeding or exclusive replacement feeding, 6 weeks, regardless of feeding option. Infants with high risk, exclusive breastfeeding means 12 weeks, exclusive replacement feeding means 6 weeks. Next. So what are the specific interventions during pregnancy, during infancy? So after delivery, we have to observe the signs and symptoms of HIV infection in 18 months. So we have to monitor for any oral thrush and any sepsis or pneumonia. And all HIV exposed infants should receive cotrimoxazole at 6 weeks of age, trimethoprim 5 milligram per kilogram per day. And we have to follow the standard immunization schedule like unexposed child. And we have to follow the routine well baby disease by referring the baby to the well baby clinic. And we have to follow infant diagnosis, that is DNA PCR test at the 6 weeks of life and 6 months of life. And routinely we have to do an, even though they are positive, we have to do a 18 months HIV antibody testing. Next. Ways in which ART reduces the risk of PPTCT. It reduces the viral replication and maternal viral load, loads fetus with ARV that prevent placentally transmitted virons from replicating, and also it treats the maternal infection, protects the HIV exposed infants from HIV infection, and it overall improves the quality of life and the health of the mother. Next. So now we'll see a different case scenarios encounter in day-to-day ART center. And what are the different type of ARV prophylaxis followed in the different case scenarios. Next. So in first case scenario is Mrs. A was initiated on ART in 2018 on TLE regimen. That is tenofovir, lamivudine, and efavirenz. She is adherent to ART. She has now reported to the ART center and informs that she is 2 months pregnant. Her latest result of viral load testing was target not detected. Question: as the medical officer, what actions will you take? So the answer for an explanation is we can counsel the patients and we have to transition to the TLD regimen and advise the mother to adhere to this ART more than 95%, and we have to link the mother to the PPTCT program and should ensure protected safe sex practices by providing condoms to avoid fresh HIV infections and promote the mother to institutional delivery for interventions during labor and delivery and timely ARV prophylaxis to the baby and feeding practices and care of breast and nipples. And we have to give nutritional supplementations, regular antenatal visits, and provide mother an antenatal checkup as well as in the delivery. We have to give iron, folic acid, and calcium supplementation. Even though the patient is in good adherence to the existing ART like TLD regimen, we have to advise transfer the patient to the TLD and we have to link to the PPTCT program. Second. Next. So next case is that Mrs. C received a triple ARV drug ARV prophylaxis in 2012 during a first pregnancy. She was advised to TLE once a day as prophylaxis and it was stopped 7 days after discontinuation of breastfeeding. Now she reports to ART center within 2 months of pregnancy. Her latest CD4 is 420 cells per millimeter cube. And what ARV regimen should be advised? Question 2. Mother viral load test done at 34 weeks of gestation was 500 copies per ml. She plans to breastfeed the baby. What infant prophylaxis should be advised for what duration? So, viral load test at 34 weeks is 500 copies per ml, and she plans to breastfeed the baby and infant prophylaxis should be advised and for what duration. So in this case, the regimen should be substituted with the PLD regimen, as I told you earlier. And regarding the prophylaxis, it comes under the low risk transmission. So in case of low risk transmission, regardless of the feeding option, we have to follow it for 6 weeks, nevirapine or zidovudine. Next. Mrs. D has reported to ART center at 7 months of pregnancy. She is ART naive and her CD4 is 385 cells per millimeter cube. What ART regimen should she be initiated on? And mother viral load report done at 36 weeks of gestation was 20,000 copies per ml. She plans to breastfeed baby. So it comes under the high risk category and the mother is opting for breastfeeding. So in case of breastfeeding, high risk means 12 weeks we have to give. And CD4 count is 385. So no need for cotrimoxazole. But we have to give regimen is TLD. So Mrs. D need to be started on ART immediately after explaining the need for lifelong ART adherence. TLD, 1 tablet once a day. Baby should be advised dual ARV prophylaxis syrup, nevirapine once a day, syrup zidovudine twice a day, both to be given for duration of 12 weeks because mother opted for breastfeeding. Next. Mrs. E was advised as a single dose of nevirapine as prophylaxis in her previous pregnancy in 2011. She was later initiated on TLE in 2014. She has now reported to ART center at 3 months of pregnancy. What ART regimen should she be initiated on? Transition ART regimen from TLE to DLD after explaining the benefits of TPG in achieving faster viral suppression. Earlier we used to give TLE regimen. Now we are doing TLD because the dolutegravir has a capacity to suppress the virus suppress is faster and compared to the TLE. That's why it's recommended in pregnant women and also in the PEP prophylaxis, and in all cases they are advising TLD. TLD is effective in a woman with a history of single dose nevirapine previously because already the NNRK exposure is there. Next. So, question 2 is mother viral load report done at 33 weeks of gestation was 250 copies per ml. She plans to breastfeed the baby. What infant prophylaxis should be advised and for what duration? So, in this case, mother is already exposed to the nevirapine. So, we have to give zidovudine. As you know, zidovudine has to be given twice daily. And the mother is opted for breastfeeding, but in this case, it is a low risk transmission. So low risk transmission means single drug is enough and 6 weeks is enough. So zidovudine twice a day for 6 weeks of life. No role of nevirapine in this case. Next. Mrs. F is an asymptomatic postnatal PLHLE who presents at the ART center 3 days after delivery. Her CD4 is 550 cells per millimeter cube. She has opted for exclusive replacement feeding. The weight of the baby is 2.4 kg. What is the next step in the management of the mother? As you know, even though in the postnatal checkup, the preferred regimen is postpartum regimen is PLD, and we have to link the mother and the baby to the PPTCT program, and we have to give advice for feeding practices. And as I said earlier, we have to take care of the breast and nipples because to avoid HIV transmission to it, and give nutrition counseling and advice for protected safe sex practices. Next. What is the next step in the management of the baby? Baby, so it comes under the high risk category. So we have to give dual ARV prophylaxis. and the mother is opted for replacement feeding. So high risk category means 2-drug regimen. Since the mother is opted for replacement feeding, we can give 6 weeks. So syrup nevirapine weight is 2.4 kg. So nevirapine 1 ml once a day plus syrup zidovudine 1 ml twice a day. If the weight is more than 2.5 kg, we have to give syrup nevirapine 1.5 ml once a day plus syrup zidovudine 1.5 ml twice a day. Next, case 6. Mrs. G was screened for HIV and found to be reactive by finger test performed in the labor room. She was immediately given a single tablet of TLD. She was linked to ART center. The next day, after a confirmatory test report for HIV was positive, and the weight of the baby is 2.8 kg. What is the next step in the management of the mother? So, 4 points to be monitored this. We are doing, the mother is reported in the labor room. So, it comes in the high risk category, and the weight of the baby is 2.8 kg. So, we have to start mother on the TLD regimen, and we have to link it to the PPTCT program. And we have to do nutrition counseling, advice infant feeding practices. Next. So, since it is high risk category, the mother opts for breastfeeding means we have to give for 12 weeks. So, syrup nevirapine once a day and syrup zidovudine twice a day, both to be given for a duration of 12 weeks. Weight of the baby is 2.8 kg. That's why nevirapine is 1.5 once a day plus syrup zidovudine 1.5 ml twice a day. 12 weeks. What is the duration is 12 weeks as the mother has opted for breastfeeding, does not taken adequate duration of ART for optimal suppression in breast milk. Next. Mrs. H is a 25-year-old newly diagnosed HIV positive pregnant woman linked to the ART center. She has confirmed HIV-1 and HIV-2 co-infections. She is 3 months pregnant and her CD4 count is 700 cells per millimeter. What ART regimen should be started for Mrs. H? Even they have HIV2 combined HIV1 and HIV2 infection, we have to give TLD. TLD is very effective in HIV1 and HIV2 co-infection. Next. So, the mother's viral load report done at 36 weeks of gestation is target not detected. She plans to breastfeed the baby. So, low risk infants. And what infant prophylaxis should be given? We should avoid nevirapine in this case. As you know, NNRT is not effective in HIV2 co-infection. So, low risk infants and HIV1 and HIV2 co-infection means you have to give zidovudine twice daily and it has to be given for 6 weeks. Next. So, Mrs. I, a newly diagnosed PLHIV, has been recently linked to an ART center with a 3 months old baby who is breastfeeding. How will we manage her? So, in this case, we have to initiate mother on TLD after preparedness counseling. Advise mother regarding care of nipples and breast, feeding counseling, and protected sex practices. Even though mother is reported at the postpartum, we have to start TLD. Antepartum, intrapartum, postpartum, recommended regimen is TLD only. Next. So, how will you manage a baby of this PLHIV? So, baby is reported at the 3 months of life. So, in 3 months means we have to send a DBS sample for DNA PCR as per early infant diagnosis algorithm, and we have to give CPT, co-trimenoxal prophylaxis therapy, to prevent opportunistic infections, mainly pneumonia and diarrhea, and ideally the baby should be evaluated by a pediatrician for presence of any clinical signs of HIV infection like sepsis, pneumonia, diarrhea like that, and failure to thrive, and referral to SAS or PCO for opinion on management of the HIV exposed babies, and we have to follow the immunization practices as like unexposed HIV infants. If DNA PCR is negative, we have to keep under regular follow-up, and at 6 months of age, perform rapid antibody test, and subsequently DNA PCR if necessary as per EAD algorithm, and take further decision accordingly. Confirm at 18 months of age as per guidelines. See, this point is very important. Even though the DNA PCR is negative at the 3 months of age, we have to monitor the signs and symptoms of HIV infection till 18 months. If the baby shows any signs and symptoms, we have to do rapid antibody test, and if it is found to be positive, we have to do subsequently DNA PCR, and if needed, positive means we have to start ART for the child. Next. This one is Mrs. K was diagnosed HIV infected recently. She has reported to ART center and informs that 6 months of pregnancy. Her CD4 is 285 cells per millimeter cube. What ART regimen should be started in this PLH? So in this case is also TLD is the ideal drug, and the thing main is the CD4 count. As you know, the CD4 count is less than 350. We have to start the mother on 4-trimethoprim prophylaxis. So we have to give 4-trimethoprim along with the ART for this patient. Next. Mother viral load report done at 36 weeks of gestation is 55,000. So it's high viral load. She plans to breastfeed the baby. So it comes under the high risk. So even though mother is out for breastfeeding means, so 12 weeks and dual regimen is advisable. What infant prophylaxis should be advised for? What infant prophylaxis should be advised and for what duration? Syrup zidovudine is not available. Baby should be advised to dual ARV prophylaxis in this case. In this case, syrup nevirapine plus syrup lopinavir to be started after 14 days of life, because zidovudine syrup is not available. It comes under the high risk category, and also mother opted for breastfeed. So we have to give 12 weeks of age. Explanation. Mother viral load report done at 36 weeks of gestation was unsuppressed. So the baby becomes high risk for infant for HIV transmission. Hence the baby will be advised 2 drugs for ARV prophylaxis, that is nevirapine and zidovudine. Zidovudine is not available. Lopinavir is there. Since the mother is opted for breastfeeding, we are giving for 12 weeks. Next. The last case scenario, Mrs. L, 26 years, was registered at the ART center in 2012. She was initiated on ART TLE in 2015. She became lost to follow-up after 1 year as she shifted to her village. She has now reported in active labor. So she is already exposed to the TLE MMRT exposure. How should you manage this patient? She has to be started on a TLD regimen, single tablet, and adherence. We have to insist mother on the adherence for adherence to the ART and preventing HIV transmission to the babies. The feeding counseling to be given and protected sex practices. Next. Mrs. L delivered a baby by normal delivery with a weight of 3.2 kg and has opted for breastfeeding. What is the next step in the management of baby? Syrup zidovudine and syrup lopinavir are both not available. So in this case, dual ARV prophylaxis advisable. Already exposed to the TLE regimen, so nevirapine is not advisable. So zidovudine or lopinavir is advisable. Since syrup zidovudine and lopinavir is not available, in this case, we can consider giving ZLN. FDC tablets as per weight band twice daily till 12 weeks. Why means why mother is opted for breastfeeding. 12 weeks as mother has opted for breastfeeding and has not taken adequate duration of ERT for optimal viral suppression in breastfeeding. Breast milk. Next. In exceptional scenarios and for high risk infants born to HIV positive mothers or for high risk infants born to mothers who had received a single dose of nevirapine during early pregnancy and delivery, the opinion of SASAB should be sought. Next. Thank you. Thank you very much.
Sir,
Yes.
thank you, sir, for this wonderful session. I will request participant to unmute their mic, and if you have any question, please ask. Participants are requested, if you have any question, please ask.
Answer again. Hold on.
Okay, sir. I think there are no question. Can we run feedback poll, sir? Hello.
Hello. Hello.
Yes, sir.
How does mixed feeding increase the risk of HIV transmission to the baby?
Sorry?
How does mixed feeding increase the risk of HIV transmission to the baby?
If you give a mixed feeding, there is a damage of the intestinal epithelium. It will prone for the HIV virus transmission. Audible?
Please clarify.
So if the mother opted for an mixed feeding means
Okay.
chance of breakage in the intestinal epithelium integrity. So the chance of HIV virus enter into the bloodstream and will cause more transmission.
No, replacement feeding may also cause that, no?
But there will be no breach in the intestinal epithelium. No? Only
Okay.
Anyone has question? Any? Please fill that feedback. Participants are requested. Thank you all for the participant. Can we conclude the session now, sir? Hello. Hello. Can we conclude the session now?
Yeah, yes, sir. Yes, sir.
Thank you.
Thank you. Thank you so much. Yeah.